It's important to know the pathways of glycogen synthesis and degradation so that you can appreciate disorders of glycogen metabolism. What happens when we have a deficiency or defect in these enzymes? Well, the glycogen storage diseases are caused by abnormal glycogen metabolism, which cause damage by allowing glycogen to accumulate to toxic levels inside of cells. There are 12 types, but we'll just review the 4 most commonly tested ones here. All 4 are autosomal recessive. Expect to see at least 1 or 2 questions regarding the glycogen storage diseases on the USMLE, so this will be a high yield section. And while most of the material that we cover is high yield, this one's really up there. Type 1 glycogen storage disease, also known as von Guericke disease, is caused by deficiency of the enzyme glucose-6-phosphatase. Remember, glucose-6-phosphatase converts glucose-6-phosphate to glucose so that it can leave the cell and travel to other parts of the body. Muscles don't really need this enzyme since they're greedy and use all the glucose produced from breaking down their own glycogen stores. It may be helpful to think that von Guericke disease affects mainly the liver and to a lesser extent the kidney. Thinking back to glycogen formation, if we have a buildup of glucose-6-phosphate, what do you think will happen? Well, since glucose-6-phosphate activates glycogen synthase, if glucose-6-phosphate is allowed to accumulate, then even more glycogen will be formed. Consequently, patients with von Guericke disease have increased glycogen stores in the liver with severe fasting hypoglycemia, since glucose cannot be dephosphorylated and therefore can't leave the hepatocytes. This also causes increased blood lactate, which can lead to gout due to decreased serum pH, and can cause hepatomegaly or hepatosteatosis, otherwise known as fatty liver. Some other effects include renal failure, delayed puberty, and hepatic adenomas. Von Guericke disease is treated with frequent bouts of glucose to ward off hypoglycemic states, since the liver is unable to compensate for the low blood sugar. Also, affected patients should avoid fructose and galactose. Type 2 glycogen storage disease, or Pompe disease, is caused by a deficiency in lysosomal alpha-1,4-glucosidase. As mentioned before, this enzyme breaks down glycogen into glucose in the lysosome. This is a very serious disease that primarily affects the liver, heart, and skeletal muscle. Remember that Pompe disease trashes the pump, meaning mostly affecting the heart, but also some other organs as well. The main finding in Pompe disease is cardiomyopathy, along with other systemic findings, like exercise intolerance. If you suspect a glycogen storage disease that focuses on the heart being affected, you need to have Pompe disease high up on your differential. The third type of glycogen storage disease, known as Quarry disease, is caused by a deficiency of debranching enzyme. What was the function of debranching enzyme? Remember that debranching enzyme is required to break down glycogen into glucose by cleaving the alpha-1,6 bonds, seen at branch points along with some alpha-1,4 bonds at limit dextrins. This primarily affects the liver and muscles, and has findings similar to type 1 von Guericke disease, but without lactic acidosis. Key point, without lactic acidosis. Again, these symptoms include hepatomegaly, hypoglycemia, and delayed growth. The hypoglycemia is milder in Quarry disease than it is von Guericke disease, and symptoms in general are more benign. This is because Quarry disease doesn't affect gluconeogenesis, which is impaired in von Guericke disease, because glucose remains trapped in the hepatocytes as glucose-6-phosphate. Lastly, type 5 glycogen storage disease, or McArdle disease, is caused by a deficiency of skeletal muscle glycogen phosphorylase, also termed myophosphorylase. Consequently, this only really affects skeletal muscle, and not cardiac muscle. You'll see increased glycogen in muscle, with an inability to break it down. So, how may a patient with McArdle present? Well, since muscles can't get enough glucose from breaking down glycogen, this will cause muscle cramps, myoglobinuria, muscle weakness with more myoglobinuria during strenuous exercise, and or arrhythmias due to electrolyte abnormalities. Would you expect to see hypoglycemia in the bloodstream? Well, not really, since McArdle disease doesn't affect the liver, which breaks down glycogen stores into glucose which can then be used for the rest of the body. So, blood glucose levels are usually unaffected in McArdle. Let's dust off our memory and jump to cell biology and organelles within the cell. Do you remember what lysosomes do? Lysosomes are organelles whose main function is to break down unwanted molecules using a variety of different enzymes. A deficiency of one of these enzymes can cause a lysosomal storage disease, which results in the accumulation of sphingolipid or mucopolysaccharide in specific cell types. Here's an example of a sphingolipid and mucopolysaccharide. Their specific structures aren't important. However, there are many buzzwords that you'll need to know for these lysosomal diseases. To make life a little easier, we've already seen one lysosome enzyme disorder. Do you remember what the disease is called when lysosomal alpha-1,4-glucosidase is missing? Well, hopefully you remember good old Pompe disease, which was one of the 4 main glycogen storage diseases. Now back to the other lysosomal storage diseases. These in general accumulate metabolic byproducts and mostly affect children. It's not necessarily that they'll grow out of it, it's that the disease phenotypes are so severe that unfortunately, most of these little tykes don't make it that long. They're all autosomal recessive, because they all deal with enzyme deficiencies, except for Fabry disease and Hunter syndrome, both of which are X-linked recessive. The general rule is that usually enzyme deficiencies are recessive, but not always the case. You'll probably get a question on your step 1 that'll ask you to identify a specific disease, inheritance pattern, deficient enzyme, accumulative substrate, or clinical findings that result from one of these lysosomal storage disorders. To get these questions right, you should take some time to memorize these diseases and pay particular attention to what distinguishes them from each other. As usual, we've provided some good ways to help you remember them. You're welcome. We'll first start off with the sphingolipidoses, which include Fabry, Gaucher, Niemann-Pick, Tay-Sachs, Krabbe, and metachromatic leukodystrophy diseases. Let's go through these one at a time and talk about the more important points. Fabry disease is a deficiency of alpha-galactosidase A, which leads to an accumulation of ceramide trihexoside. What were the 2 X-linked recessive lysosomal disorders? Hopefully you remember Fabry disease, since that's what we're covering now, but also Hunter syndrome. All of the other lysosomal disorders we will cover are autosomal recessive. Fabry disease can present with angiokeratomas, which signify a capillary disorder seen here. Gaucher disease is the most common lysosomal storage disorder. Since it's the most common, you can bet that your chances of seeing this disease on test day are pretty high. Don't just memorize this one though. It's quite common to find questions about the second most common or third most common. So, which enzyme is defective in Gaucher disease? The enzyme glucocerebrosidase is defective or missing, leading to an accumulation of glucocerebroside. Another important pearl for Gaucher disease is how the cells look. Gaucher cells are lipid-filled macrophages that look like crumpled tissue paper, as seen here in this picture. You may also be presented with a young child who presents with symptoms of hepatosplenomegaly, pancytopenia, osteoporosis, and aseptic necrosis of the femur. Be prepared to see a picture similar to this one on test day. Niemann-Pick disease is caused by a sphingomyelinase deficiency, which leads to sphingomyelin building up. What's a quick way to remember this? You need to use your finger to pick your nose. Silly, but it'll work come test day. In Niemann-Pick disease, you'll see lipid-laden macrophages called foam cells. Also, if the question prompt says that on fundic exam you see a cherry red spot, Niemann-Pick disease should cross your mind. An excellent way to remember which diseases have a cherry red spot is by looking at the hyphen. Cherry red is hyphenated, and so is Niemann-Pick and Tay-Sachs, both of which have hyphens as well. For you gunners out there, a less common cause of these cherry red spots is retinal artery occlusion. If the spots occur in an adult, think of this. Otherwise, if they're in the young, think of the other 2 first. So Tay-Sachs disease can present with cherry red spots in the macula as well. Tay-Sachs is another extremely high-yield disease, so remember that GM2 ganglioside builds up due to hexosaminidase A deficiency, because Tay-Sachs lacks hexosaminidase A. If you read or see a picture of a lysosome with an onion skin appearance, consider Tay-Sachs disease. What are the other 2 sphingolipidoses? Krabbe disease and metachromatic leukodystrophy are 2 more lysosomal disorders that result in an abnormal breakdown of sphingolipids. While they're less important, make sure you know them still for test day. The mucopolysaccharidoses can be classified into 2 different yet similar disorders. Hurler syndrome is due to an alpha-L-iduronidase deficiency, which leads to an accumulation of heparan sulfate and dermatan sulfate. Hurler syndrome is the more severe of the 2 mucopolysaccharidoses, so if you're ever diagnosed with this disease, you'll probably want to hurl. Again, cheesy, but it'll help come test day. Symptoms include corneal clouding and figurative gargoylism, which is joint and movement restriction, also along with hepatosplenomegaly. Do you remember what the two X-linked recessive lysosomal storage diseases are? I'm trying to drill this point home because all lysosomal storage disorders are autosomal recessive except for these two. Hopefully you're thinking Fabry disease and Hunter syndrome, the latter of which is our final mucopolysaccharidosis. Hunter syndrome is just a milder form of Hurler syndrome, without the corneal clouding, but still includes some aggressive symptomatology. Notice how the same products accumulate in both mucopolysaccharide disorders. Okay, so this is a lot of material, but don't freak out. I recommend that you try to memorize these in a methodical manner, such as by making sure you're very familiar with each disease before moving on to the next one, and going back and reviewing the ones you've already learned after you go through each subsequent one, so that by the time you get to the end of the list, you'll already have looked at the beginning a few times. Repeat key points to yourself aloud or by copying them down a bunch. Return to these often to quiz yourself. Make sure you know these because they will show up on test day. Promise. To learn the clinical findings for lysosomal storage disorders, focus on the distinguishing characteristics of each disease. For example, Fabry is notable for angiokeratomas, Gaucher for bone necrosis, and metachromatic leukodystrophy for ataxia. Niemann-Pick and Tay-Sachs both have cherry red spots on the macula, but Niemann-Pick has hepatosplenomegaly, whereas Tay-Sachs does not. Hurler is notable for corneal clouding, which is not present in Hunter. The disorders that cause hepatosplenomegaly include Hunter and Hurler, Niemann-Pick, and Gaucher. What three diseases should come to mind if you see Ashkenazi Jew in the question prompt when referring to lysosomal disorders? The term Ashkenazi Jew should conjure up Tay-Sachs, Niemann-Pick, and to a lesser extent Gaucher disease. Okay, flash quiz time. Let's do a quick practice question before moving on. A patient is diagnosed with Gaucher disease. What is the deficient enzyme, accumulated substrate, and inheritance pattern of Gaucher? The missing enzyme is glucocerebrosidase, which causes glucocerebroside to accumulate. Gaucher disease, along with all other lysosomal storage diseases, minus Fabry and Hunter, are autosomal recessive. Notice how they all have in common enzyme deficiencies. Usually enzyme deficiencies are recessive in order. It just depends on where they are on what chromosome.